I would like to thank the organizing committee for asking me to speak on this topic. I'll be speaking on refractive DMEs. Diabetes mellitus is going to be a big global epidemic, and DME is the most common cause of visual loss in diabetic eye. DME pathogenesis is extremely complex, as we all know, and it is very important to identify each contributing component to plan its prudent management. The introduction of anti-VEGFs led to a breakthrough management in DMEs, and differences between anti-VEGF drug has been explored by Protocol T, and they find that each drug was found to be improving vision as well as reducing the CRT. But despite the efficacy of anti-VEGF agents, at least 40 to 50% of DME eyes experience persistent DME after at least 6 monthly injections of anti-VEGF, and 32% of them have concomitant visual loss. So it's a big data. Persistent DME remains a challenge because it leads to permanent disruption of retinal architecture, causing photoreceptor loss. What is persistent DME? DRCI.net defined it as eyes with CRT of greater than equal to 250 microns at 6 months of follow-up, despite receiving at least 4 of the potential 6 protocol-mandated anti-VEGFs during this period. So despite of receiving good number of injections in initial phase, 40 to 50% of the patient will be landing up in persistent DME, or what we call as refractive DMEs. So what all we need to do? From the very beginning, it seems like 4 of the 10 patients will be landing up in persistent DME, so we need to plan it well. So from the very beginning, we need to look into the systemic status of the patient. We need to go into the drug history of the patient, check for any surgical histories, ensure compliance at the very beginning of the management, do counseling of the individual patient as well as their families, and do routine baseline investigations. Biomarkers play a very important role in deciding the future outcomes of these patients. Ellipsoid joint disruption, disorganization of inner retinal layers in 1 mm foveal zone, and lower parafoveal vascular density in the superficial layer of OCT are poor biomarkers of final visual acuity gain and improvement in the CRTs. Some studies have suggested initial subfoveal choroidal thickness to be checked. Greater baseline choroidal thickness are more likely to respond to anti-VEGFs. As we all know, presence of SRF and hyperreflective spots denote inflammation, and certain studies have told that in these cases, steroids work better. Recently, aqueous humor cytokine levels have been used as biomarkers that could help anticipate response to anti-VEGF therapy, and elevated ICAM-1 and reduced VEGF levels at baseline were associated with favorable anatomical outcomes with anti-VEGFs in DME. So when you are landing up with so many patients in refractive DMEs, what is the treatment protocol? What are the options that we have? What all things that we can do? So we can do either anti-VEGF switch, we can switch to steroids, we can plan vitrectomy, or we can add lasers. So we'll go through them one by one. Anti-VEGF switch means that whatever anti-VEGF you are starting with, if your patient is not responding or has stopped responding to that anti-VEGF, you shift to the next one. What I routinely start with is ranibizumab, and when it doesn't work or it stops working, I shift to aflibercept because it has shown superior effects on vascular permeability and make it more suitable for high VEGF levels. If my aflibercept patients stop responding, then I shift to either Broly or faricimab of late. So these are the few patients which started with ranibizumab and landed up with refractory before shifting it to aflibercept, and few of them responded nicely, as you can see on the right side. Question is when to shift. DRCR says after 6 consecutive monthly injections. But that is not practically possible in our scenarios, and what in practice we do, or what the latest studies are telling us, is that after 3 consecutive monthly injections in treatment-naive cases, or 2 consecutive monthly injections in cases who stop responding to the injections. but ensure that patient don't drop out of the treatment, because we have seen that patients who drop out and do not take injection for 2 to 3 months, they generally land up in more refractive DMEs. When to shift to steroids and why to shift to steroids? Because as we all know, it is stronger anti-inflammatory, acts on various pathways. Again, the question is when? Not after 6. Again, the study says that persistent DME might benefit from a switch to dexamethasone implant early. That is, after 3 anti-VEGFs rather than 6. So these are my case, same case in the right eye and the left eye. Right eye we kept giving anti-VEGF and kept responding, but on the left eye it didn't respond well to anti-VEGFs, and then we treated with steroids and patient improved certainly. Going to lasers alone does not work well, as we all know. But of late, there is a lot of interest in micropulse lasers when you add it with anti-VEGFs. When lasers are added with, micropulse lasers are added with anti-VEGFs, many studies have proclaimed better anatomical as well as visual outcomes. But all these studies are having limitation as they are small sample size, retrospective and short follow-ups. Coming on to the surgery, it has a proven effect in tractional DME, but no consensus so far in non-tractional DMEs.
Shashank,
Positive save.
time is up, but you can extend one more minute. Yes, we have a lot of time afterwards.
PPV leads to, it allows VEGF and pro-inflammatory cytokines to diffuse, but on a negative side, it reduces the half-life of intravitreal agents. So I skip this and come to this picture. So what we proclaim and what later studies are proclaiming, that rather than giving many anti-VEGFs and steroids and then landing up in this case and then think about surgery, same in this eye and the other eye, we should think about the surgery early in the course. So not after trying all anti-VEGFs, all steroids, all lasers, and then we come to surgeries. Rather than that, we should come to think about surgeries early in the course as we do anti-VEGF shift or steroid shift. After 1, 2, or 3 injections, the surgery will work then better and will give more structural as well as functional outcomes rather than doing it in this stage. So there are future perspectives. Many new molecules are coming, which may individually or in combination help us reduce this load from 40 to 50% to maybe 20 or 10. This is what all of us are working. Thank you so much, and I invite you all for 10 Delhi Retina Meet in Delhi. Thank you.
Thank you, Shashank. It's a nice presentation, but it's very complex. Your presentation itself shows that it is very complex problem, and there is no single answer for all the audience. I am telling, if some refractory diabetic macular edema comes, what is your first step? Shashank, where are you?
Sir,
What is the first step?
First step is definite.
Someone has taken multiple injections, has defined chronic macular edema. He came to your clinic now. What is the first step you are going to take?
Sir, if patient has already taken multi-anti-VEGFs and is not responding, first of all, you tell the patient that chances of you responding are very less. So I, rather than treating that patient at that stage, I would like to shift early. Rather than trying 6 anti-VEGFs, I try to do 1, 2, or 3 anti-VEGFs and then do a surgery. Because whenever I am doing surgeries with ILM peeling early in the course, I am getting good structural and functional results, and there is almost total disappearance of DME when done in time. And you don't need repeated injections.
No, I would first rather go into the systems, whether this patient is having a deranged systems. Most of the time, believe me, people who have come with multiple injections, their systems are deranged very worse. So you need to stress upon that unless your body is under stable status, you are not going to respond. This part most of the people miss. What systems will you look in if the patient is?
That is the basic understanding that we...
I understand, but people stop.
We need to check the HbA1c levels, we need to check the cholesterol level, we need to check the blood pressure, we need to check the nephropathy and anemia. So all these factors have to be looked into. If any of them are deranged, that has to be simultaneously worked upon and bring to an optimum level.
And cardiac, you should also look for sleep apnea, and microalbuminuria. Most of the people declare that their kidneys are all right, but they are deranged grossly on microalbuminuria. This need to be taken care. Means a chronic diabetic macular edema is an indirect indication that fluid retention is happening in the body, and you need to address that. Unless you are addressing that, injections do not help. Second, once you are committed for injections, it is a limited period. You need to stress on the patient that you need to get all right, otherwise I may have to repeat the injections one after the other. So there is nothing called very refractive this thing. This is mainly because the patient is insensitive for your treatment. He is also tuned to, okay, only injections is the treatment and nothing else. So we are hitting the wall in those cases. So diabetic macular edema, your approach should be holistic rather than a simple repeat injections or not.
Rightly said.
Post-vitrectomy macular edema, how to deal? Post-vitrectomy macular edema.
So the only option is dexamethasone for longevity sake. Otherwise, you can try repeated frequent anti-VEGFs.
Yeah, implants is the answer for those
Yes,
cases
long
because the turnover rate for this thing is very faster, all the other injections. One thing which I say the surgical option, if you see the OCTs, there is hyaloid, though it is not traction, there is a thickened hyaloid is
Short
there.
posterior hyaloid.
Yeah, generalized traction will be there.
But in
these
those cases, it didn't start up with that. It landed up with that during the injections.
I know that, but once it happens, the
Yes.
traction is persistent
Yes.
and reason for the this thing, you should address that and relieve that. That would be another option which you have. Thank you very much.